Okay, good evening, everyone. And I know this is not a good time to have a lecture, and this is a time for outdoor games and other activities. But still, then, being professionals, you should have a thorough idea about how to diagnose things. That means when it comes to the diagnosis of infectious diseases, there are a lot many techniques there, and there are a lot many people to help you. Laboratory peoples are there to help you. But when it comes to diagnosing a non-infectious disease, many a times you will be alone, and it is your skills will help you only to make the correct diagnosis and go for the or start with the treatment of your choice and get good result. There comes the importance of radiography, and radiography plays a vital role in the diagnosis, or rather you can say the start of any diagnosis of any non-infectious disease starts with radiology or radiography. To start with, and I trust and I hope every one of you might have seen this image. I think the answer is yes, and this is the hand of Mrs. Anna Bertha, which is a wife of Rongen, and this is supposed to be the first, considered as the first X-ray ever taken in the world. This was an accidental discovery, or rather you can say accidental happened when the Rongen was working in his laboratory, and his wife entered in the room, and accidentally he could see some image like this. And this is for information, this is Rongen, and this was an accidental discovery, and he at that time he was not knowing what is this this rays and which give a very good image like this, so he named it as X-rays. And later the science discovered that this is having a very good diagnostic value, and they tried to give his own name, but he was not willing for that, and this name continued as X-rays. Actually, we can say that this discovery of this radiography or X-rays revolutionized the field of medical diagnosis. And after that, a lot of change happened in the field, keeping this radiography or X-ray as the base. But still now also, in case of veterinary patients or in medical practice, see, radiography continues to be the mainstay diagnostic tool when it comes to make a correct decision to take the correct and appropriate treatment for the patient. Okay, so with keeping this thing in mind, we will start with why or what is importance with the thoracic radiography. What is importance, or why we want to go for thoracic radiography? Because thoracic radiography is a very good and vital tool for confirming or diagnosing many of the pulmonary pathologies. And not only that thing, it helps in quantification of the cardiac size, shape, and even chamber size as well. That we can come see in the coming slides how this is being done. And all other associated structures like mediastinal parameters, pleura, any abnormalities in these areas also can be easily diagnosed by radiography. And that is the importance of going for thoracic radiography. And when you want to get a good quality radiograph, it starts with the technician who is taking the radiograph, and there comes the importance of positioning of the patient. So positioning of the patient correctly is very important to get an ideal or quality radiograph for you to interpret. And always keep it in mind the fact that you are actually taking, when an X-ray is taken, it's actually a 2D representation of a 3D structure. So the structure on the table is a 3D structure, and what you are getting, the printed one, it is called Röntgenogram or the skyagram. It's a two-dimensional representation. So there can be chance of the superimposition of the structures as well. So that is why it is said that whenever you plan or for a radiography, or you send for a patient for a radiography, always go for two views. That is called orthogonal views. That means two views at exactly 90-degree angle. And why this has been taken is that, and I told you this is the reason, it's a 2D representation of a 3D structure. There is every chance of some structures getting missed in one view. To avoid that one also, or to compensate that loss or that miss, we have to go for another view at 90-degree angle. That is called orthogonal views. And when it comes to thorax, and the views commonly used views are lateral view. You can go for a lateral view. Again, lateral view can be of two different types. It can be a right lateral view, or it can be a left lateral view. In the coming slides, we will see how this is being done. Or you can go for another view, is a ventrodorsal view. Ventrodorsal view, or it can be dorsoventral view. Ventrodorsal means first the X-ray passes through the dorsal side, ventral side, and then comes out through the dorsal side. That is the ventrodorsal. And when you say dorsoventral, that means the first X-ray passes through the dorsal side and enters through the ventral side. So whenever you say there is a two terminology, two words in a view, ventrodorsal means first part depicts the part through which X-ray enters the body and comes out. This is not only not done in case of lateral view. There you can see X-ray enters the body through a lateral side and comes out through another lateral side. Only thing is that its side changes, that is right or left. That's the only difference. And in any other part of the body, two views will be sufficient. But if possible, if you are sending a patient for thoracic radiography, it is always said that not two, if possible, you go for three. That means a right lateral, left lateral, and either ventrodorsal or a dorsoventral view. So three views are mandatory. This is why, because you are getting a 2D representation of a 3D structure. And this makes it very clear about why this, and I think you all might have seen this image as well. This is a very the popular image where the lady is standing with a pineapple in one hand and a lighted candle in the other. This is to demonstrate how this appears, to what is important. So two views. So if this,
Anoop, sir?
Yes, please.
Sir, the slide is not changing, sir. Okay, sir. Thank you.
It's moving now?
Yes.
Okay. Sorry for the inconvenience. Here you can see, and if this lady is imaged, if you are going for an anterior posterior view, so you will finally end up with an X-ray image like this. Here you will be seeing only the lady standing with a stretched hand, and this is actually representing the lighted candle. So this pineapple and the other hand is shadowed in this image. And at the same time, if you are going for a lateral view from this side, if you are taking a radiograph, and finally you will get an X-ray like this. Here the thing is that this hand, this stretched hand and the lighted candle is missing in this image, and you can see only a stretched hand with a pineapple. So there comes the importance of going for two different views. So if this is taken, and if you can put the images in a stereoscopic view, you can get a three-dimensional, or at least if you have two different views at 90-degree angles, at least that is help you to counter the lost things in one view. And I think the next coming slides makes it very clear. This makes this concept very clear. Here you can see a lion walking with its cub, and if you see only this image, we will think that this is done, this is finished, the cub is finished. But actually, in reality, what is happening is that it is holding its neck only. So here you can see the head is perfectly there. So this is the importance of going for two different views. So whenever you send, not only thorax, any part, always go for two views at 90-degree angles. The next picture makes it very clear. See this image. So how dramatic or drastic results it can invite, or see actually what he is doing. This is the importance of going for this picture clearly depicts why it is important that you always go for two different views at 90-degree angle whenever you radiograph or image any part in the body. So coming back to the thorax, again I told you we can go for lateral view. So in this case, the patient is lying on one side. And here you can see the right side is touching the cassette and on the table. This is actually the animal is on right lateral recumbency. So then you can say that animal is a right lateral radiograph. So that means right lateral radiograph means animal will be on its right side down and the right side touching the plate or the patient. So here the thing is happening is that the X-rays are passing through the left side and enters or coming out through the right side. But here the patient will be on right lateral side lying, and then the image will come as a right lateral radiograph. And if the patient is on the left side lying with the left side down, then it became the left lateral radiograph. So that's the difference between right lateral and left lateral. Right lateral means the patient will be on the right side down. And when you get a right lateral radiograph for interpretation, it will be appearing like this. And there the main structures coming that we will discuss later. So this is the area for the lungs, you have the heart, you have posterior vena cava, so you have the pulmonary vessels to the caudal lung lobe, this is aorta, trachea, and also the anterior vena cava. And these are all the structures what you are going to see, and these structures comes inside the thorax. So whenever you are getting a radiograph for interpretation, the first thing is that you have to mount it on a viewer. And when you mount a lateral radiograph, let it be right lateral or left lateral in a viewer, it should be done in such a way that the dorsum should come on the uppermost. So this is the dorsal side, it has to come on the upper side on the viewer. Ventral side should at the bottom. cranial side to the left of the left side or to your left side, caudal part to your right side. So that means whenever you are mounting a lateral view in a viewer, always the head of the animal should be towards your left side. This should be the only method allowed, and you should not do it on the other way. So the cranial side always should be towards, or the head of the animal should be towards your left side. So this same in case of right lateral or in case of left lateral view. And again, there can be a difference in between the right lateral radiograph and left lateral radiograph. So here is the difference. So this is representing the crura or crust of the diaphragm. So this is a diaphragm, and this is also the diaphragm image of the diaphragm. You can see the difference between these two. So this represents a right lateral radiograph, and this is actually representing a left lateral radiograph. So here the difference is that in case of right lateral radiograph, both the crust or crura of the diaphragm runs parallel, whereas in case of left lateral radiograph, it takes a Y shape. So when the crura or the crust of the diaphragm take a Y shape in the radiograph, you can say that the animal was controlled on the right and left lateral recumbency, and the X-ray is a left lateral radiograph for the thorax. Whereas if you see both the crura or the crust of the diaphragm runs parallel, then you can say that the animal was on right lateral recumbency, and the X-ray is a right lateral radiograph for the thorax. Is it clear? It's very important. So identifying right and left radiography is very important, because this plays a very vital role in coming the slides or interpreting the lung patterns. Okay. And another thing what you have to keep in mind is that this is actually representing the posterior vena cava. Posterior vena cava normally enters or penetrates through the right crura or the crust of the diaphragm. Here you can clearly see it is entering, it is ending here. So posterior vena cava ends here. That means it has penetrated the right crura or the crust of the diaphragm. Here you can appreciate this is the shadow of the posterior vena cava, and it is continuing and it ends here. That means it is penetrating the crura or the crust of the diaphragm. So that means in case of left lateral, this represents the right crura, and this is the left crura or crust of the diaphragm. Whereas in case of right lateral, this is a right crust and this is a left crust or left crura. And the another view is that you can go for either a dorsoventral radiograph or a ventrodorsal radiograph. So here you can see the patient is controlled for a ventrodorsal radiograph, because the ventral side is facing the X-ray tube head, and the X-ray first falls through the ventral side, and then take an exit through the dorsal side. So that became the ventrodorsal radiograph. And always, whenever you are controlling it, always try to pull the forelimbs towards on the other side, so that to stretch it completely, so that it won't mask it, or else the muscles in these regions, in the arm region, can get a shadow in the thorax, and then it can affect the quality of the radiograph. And this the same thing has to be done in case of right or left lateral radiograph also. When you get a dorsoventral or a ventrodorsal radiograph, it will be appearing like this. This represents the lung area here. This is actually the left lung lobe, and this is a right lung lobe. And then you have the heart here in the mediastinum. And when you get a DV or a VD radiograph for interpretation, it should be mounted in such a way that the cranial side should be on the uppermost part, caudal side on the bottom, left to the right. That means the left of the animal to the right side of the viewer, or to our right side, and the right side of the animal to our left side. Okay, so this represents the cranial side, this is a caudal side, this represents the left side of the animal, and this represents the right side of the animal. Here you can see the heart is kept in the middle mediastinum, and it is somewhat towards the left side also. So this our right side will be animal's left side. Okay, this is the same in case of ventrodorsal and dorsoventral radiograph. Now, how can we say that the technician has taken a dorsoventral or a ventrodorsal radiograph? This is also very clear. Just like in case of lateral radiograph, you have the parallel running of the crura on the crust of the diaphragm and a Y-shaped. Here, in case of VD and DV, there is also a difference. You can see in case of ventrodorsal radiograph, you can see this is the crust of the diaphragm or the crura of the diaphragm. This takes a Mickey Mouse ear appearance. Here you can appreciate this one, Mickey Mouse appearance. So this is representing the left crura of the crust of the diaphragm, and this is representing the right crura of the crust of the diaphragm, and this is the cupula. And if you can see a Mickey Mouse appearance, then that represents a ventral dorsal radiograph. And also, if you are seeing a dome-shaped appearance of the crust of the diaphragm, you can say that it is a dorsoventral radiograph. So in case of ventral dorsal radiograph, you will see a Mickey Mouse appearance, whereas in case of dorsoventral, it will be a dome-shaped structure, what you can appreciate. So this is the difference, this is the mechanism by which you can differentiate a ventral dorsal and a dorsoventral radiograph. And again, when it comes to lateral radiograph, in what stage this was taken? So you can take and expose the patient during inspiration or expiration. That also matters a lot when it comes to the interpretation, because during inspiration, the air content in the lung will be more, and you can see a much more black area, so that see the structures will begin. The contrast between the structures will be more, and it will be easy for you to have a diagnosis of the heart as well. So whereas in case of during expiration, if the X-ray has been taken during expiration, you will see the lung volume will reduce, and the contrast also will be going down, and just interpreting the cardiac silhouette and cardiac shadow and other the structures will be much more difficult. So that means X-ray has to be taken during inspiration. So X-ray of the thorax, if possible, has to be taken. In case of humans, it is absolutely possible. You can control the breath, and you can say the patient that stand with the full air inside, or that means inspiration, and then X-ray can be taken. But in case of veterinary patients, it is practically impossible to control this one. But still, then by seeing this seeing the radiograph, you should be able to diagnose whether it was taken during inspiration or expiration. Again, in case of ventral dorsal radiograph, also you can see the difference. Sorry. If it is taken during inspiration, you can see now the lung is fully expanded, and you can see, and it is diagnosing the structures of the cardiac parameter. Everything will be very easy in case of during inspiration. Whereas in case of if it was taken in the expiratory phase, you can see again lung volume will be less, and the cardiac shadow also takes a little bit changes in during expiratory phase. So if possible, always try to take a radiograph of the thorax during peak inspiration. And again, when it comes to the densities or radiographic densities, there it is said that there are 5 densities starting from the air to metal. So this means air will have the least subject density, and at the same time metals will have the maximum subject density, and accordingly exactly the reverse, you will see the radiographic density. Radiographic density is actually nothing but the degree of blackness you appreciate in a radiograph, processed radiograph. So that means if you see more black color in the radiograph, that means it is a radiographic density is more. Whereas if you see more white color in the radiograph, processed radiograph, that radiographic density is less. Exactly, this is exactly inversely proportional to the subject density. That means air will have the maximum density in a processed radiograph. At the same time, metal will have the least density. So in rather nutshell, you can say there are 5 densities, and it may vary from air, fat, soft tissue, bone, and even metal. So if you know these densities, then it will be easy for you to take a look into the X-rays and have a proper diagnosis. And another factor you have to consider when you get a processed radiography is a contrast. Contrast is nothing but the degree of difference in blackness between the adjacent area. So here you can see this is a radiograph with a lot of color between black and white. So that means here you can see all bones are taking a white in color. The heart is showing a little bit much less density than bone, and the esophagus, trachea is taking, then lung is having a different density. Blood vessels, everything have different densities. Whereas when you come to this image, you can see the entire area now is totally black, and the bone, everything is taking a white shape. So that means here you can see there is a high density. High density means a high contrast. That means this part, the degree of difference between adjacent part is very high. That means it have a high contrast. Whereas in this one, there you can see the degree of blackness between the adjacent areas is not that high as the other one. So that means this is having a low contrast. So a low contrast one will have a long scale contrast. That means you have a degree of color patterns between black and white. That means light gray, dark gray. That likewise, you can see a lot of color difference there from black and white. Then it became long scale contrast, short contrast. Here you have a short scale contrast because you have only black and white. but you can say it is having, the X-ray is having a kind high contrast and a short scale contrast. Now I think you can answer what type of X-ray or what type of X-ray you need for you to get a diagnosis. Definitely the answer should be a long scale contrast, and this totally depends on the technician who is taking. So this is another important factor after positioning the radiographic parameters. So fixing the radiographic parameters is very important. So there should be a parameter chart, fixing chart will be there. Accordingly you take a radiograph, and finally you are demanding from the radiographer that you should need a long scale contrast radiograph rather, or you can say you need a radiograph with a low contrast. Okay, I think that's very clear. And if you want to see the different structures, it will be like this. So metals will have a totally white one and up to the air. So this is the subject density wise, subject density maximum, subject density less. And in the radiograph, you will see the radiograph density maximum for air, sorry, and a minimum for metal. Accordingly, you can see the different structures also will take air, fat, bones, or tissue, muscles, and if some implant, if it's there, metal implant also will be taking different color in case of human as well. So whatever may be the X-ray you are getting, it's a good quality or bad quality. So when it comes to the interpretation, it will be like answering this question: how many legs this elephant have? And I know you will have an answer now. So some people will say that all on a sudden 4. That is actually a prejudiced answer. So never you should be prejudiced and look into a radiograph. So when you get a radiograph for interpretation, you should not be prejudiced. Have with a free mind, you look all through the radiograph outside in, or rather it is said that outside in, and look all the parts with a free mind, and then you diagnose. So this is nothing but a visual illusion. Sometimes you may see more number of the legs. Actually, to be frank, this elephant only have one leg. This is only leg. The other things are visual illusion. So never. So with a free mind, you approach a radiograph. So if it is a thorax, so it will be a lateral radiograph, and it's a right lateral or left lateral. It's a question for you. This is I know sometimes. I know that you may be knowing it. This is actually right lateral because both the crus or crura are running parallel, and these are all the factors, or these are the structures you can appreciate here. And the middle portion, you will have a cardiac silhouette here, and this is a cranial lung lobe, and you have the caudal lung lobe, apical lobe, and you have the posterior vena cava here, and these are all the pulmonary vessels. And you have the trachea, or the landmark of in the thorax is the trachea. And you can see the other pulmonary vessels here. Okay, these are all the structures you can appreciate inside the thorax. And the thorax starts from the thoracic inlet to the diaphragm. This is the area what we are going to deal with now today. So when you get a radiograph, the most important structure inside the thorax will be, of course, no doubt, it is the lungs. And so there is some difference. Here you can appreciate this animal. So the crura, both crura and the crus of the diaphragm is taking a Y shape. So that means it clearly says that the animal is on left lateral recumbency. So when the animal is on a left lateral recumbency, the left lung collapses, and what you are seeing is actually the shadow or image of the right lung. Okay, so if the animal is on right lateral recumbency, right side lung collapses, and what you will see is the shadow of the left lung. Here in this case, the animal is on left lateral recumbency, and what you are seeing is the right image of the right lung. So right lung have 4 different lobes. So you have the cranial lung lobe here, middle lung lobe here, apical lobe, and also the caudal lung lobe. So 4 different lobes are there in case of right lung, whereas in case of left lung, you have only 2 lobes. That's a cranial lung lobe. It's actually a bifurcated structure. You can see cranial, and cranial caudal will be there, and as a caudal lung lobe. So left lung will have only 2 lobes, whereas right lung will have 4 lobes. And if the animal is on right lateral recumbency, what you will be seeing will be left lung. And when the animal is on left lateral, you will see the right lateral. So if your area of interest is the heart, definitely you should send the animal for right lateral recumbency, because right lung has to collapse, and cardiac silhouette or heart, as we discussed earlier, is placed somewhere in the mediastinum, in the middle mediastinum towards the left side. So it will be giving, it's a left lung will be giving much more window for imaging heart. That is why it is said that if the area of interest is a heart, always position the animal on the right lateral occupancy and get a right lateral radiograph for interpretation. And when coming to the structure inside the thorax, for you to understand, this is actually the lung, which is covered by the pleura. So you have the visceral pleura and the parietal pleura. This take a fold here, and there is communication of pleura in the pleural space in case of dogs. And of course, you can see this is a mediastinal space, and you have mediastinal structures, anterior mediastinal, cranial mediastinum. You have the middle mediastinum and also caudal mediastinum, and the structures coming inside the mediastinum also can be easily visualized. So when you get a radiograph of the ventricular radiograph for the same structures what you have seen, this is the one. So you have this is actually the right lung. So this is a left lung, and you have the heart in the middle mediastinum, and this is actually the cranial mediastinum. This is the cranial mediastinum, and if you want to say, normally if we want to say that the mediastinum is okay, normally a rule of thumb is that it should be extending only the 2 thoracic vertebral body length. So that means this is actually the thoracic vertebra. So thoracic vertebra, 2 vertebral body length should be the maximum area for the cranial, the mediastinum. And you have the middle mediastinum is completely occupied by the heart, and it extends towards the caudal mediastinum as well. Okay, again you can see here the heart is towards the left side. This is a normal radiograph, and the heart is towards somewhat left side. So the here is the right lung lobe, and here you can see the right lung lobe will have, as I told you, there are 4 different lobes. This area represents the pleura. So when you have a suspicion that the animal is having a pleuritis or the start of the pleural effusions, these are the area where you can see the pleural fold, or it's called as a pleural fissure. So pleural fissure will be the first thing appear in a radiograph when the animal develops some pleuritis, or if sometimes if it is going towards the pleural effusion. These are all the area where you have to see whether there is any fold developing, all the fold or fissure, which is called as the pleural fissure. Now here again you can appreciate this is actually the area for the cranial lung lobe. This is the caudal lung lobe. Here in the cranial lung lobe, you can appreciate a mass here. I think everybody can appreciate the mass, because this is the area of the cranial lung lobe. This should be totally black in color because of the air, presence of the air. But here obviously you can appreciate a mass, round mass here. Why I said this is a mass is that if it is more than 3 centimeter in length or in size, you have to depict it as a mass. It's not a nodule. This is actually, I hope somebody will be having the answer what this could be, this condition. This is whenever you get a radiograph like this for interpretation, there will be every chance of a confusion developing, whether it is in the lung or it can be there in the mediastinum. Of course, that doubt has to be cleared, and definitely you need to go for other view. Here the dorsoventral radiograph was taken. Here you can appreciate this is a mass what you are seeing here. So this is a mass. This is there in the mediastinum, not in the lungs. So this is later this was diagnosed as a thymoma. So that is a thymus gland. It got this it's a tumorous, and it became thymoma, and this is actually the portion. So this again I am emphasizing the importance of going for 2 different views. So just with this view alone, if you are trying to interpret, sometimes you may end up with you saying that there is an alveolar pattern, and you will treat the animal for some pneumonia. But the condition is actually the reverse. So there comes the importance of going for 2 views again. So any mass in the mediastinum also has to be ruled out. Again, so something related with the mediastinum. Any answer for you? So what it will be the condition? Here again you can see this is actually representing the mediastinum. Here the air has gone and trapped into the mediastinum. How can you say that the air is trapped there? You can just see this. Normally you will not be able to appreciate the intestinal, the esophagus. See, this is actually the shadow of the esophagus, and normally trachea you can appreciate. So if you can clearly demarcate the images for the trachea and also the esophageal wall also, this is highlighted. So that clearly says that air is entrapped in the mediastinum. This can happen when there is a trauma happens even to the jugular vein or any structures inside the thoracic inlet. Air can go in and trapped into the mediastinum, and if air is getting trapped there in the mediastinum, it clearly highlights the margins or walls of the both trachea and esophagus, and that is called as a pneumomediastinum. It's called a pneumomediastinum. So here the air is there in the mediastinal space. So this will be the classical image of a the pneumomediastinum affected dog. Now coming to the patterns, pulmonary patterns, or the affections of the lungs, you can see. Say first pattern is called a bronchial pattern. So this is called a bronchial pattern. So bronchial pattern. So what you are to look into the radiography is that whether there is any structures like donuts. So here you can appreciate this is a donut. A lot of donuts here and there you can appreciate. This is actually nothing but a ring-like structures. This is actually the thickened bronchial wall. So what is happening in case of bronchial pattern is that whenever there is thickening of the bronchial wall, in these cross sections you will see donut-like structures. A lot of donut-like structures, and sometimes you will see tram track. Tram track means tram railway tracks. So that happens when there is a sagittal section of the bronchi. In case of sagittal sections of the bronchi, you will see just like a tram. Tram is actually a train which is there running in Calcutta and some metro cities as well. So this will be like a railway track. So that is represented by the thickened bronchial wall sagittal sections. So in a field of lung itself, if you see a lot of ring-like structures like donuts and a railway track like tram tracks, then you can give a diagnosis that it is nothing but a bronchial pattern, and the animal may be suffering from bronchitis or even bronchiectasis. So in case of bronchitis, there could be cellular infiltration taking place in the bronchial wall and finally giving rise to an appearance of the donuts and tram track. And if you see that one, you can declare it as a bronchial pattern, and also it could be bronchitis. Then you have the alveolar pattern. This is very important. Alveolar pattern, here we can appreciate this is a lateral radiograph of a dog affected with pneumonia. Here you can appreciate air in the alveoli is totally replaced. Here you can appreciate air in the alveoli. So you cannot appreciate the lung area. Rather, the entire air from the lung has been replaced by the fluid. Normally, which happens in case of pneumonia, the fluid exhalation could be there that fills the entire alveoli. Now, the entire alveoli is now much more opaque, and at the same time, you can see the bronchi. So you can see the bronchi is air-filled bronchi. You can appreciate. So this is called air bronchogram. Air bronchogram. So what? So air bronchogram means when the alveoli is filled with the fluid, and when it loses its normal black color and it's more opacity is there. At the same time, when you see the bronchi with air-filled bronchi, you can appreciate that is called air bronchogram. So here you can clearly see the air bronchogram, and this is actually the first sign of alveolar pattern. And then you can see a lobar sign. Lobar sign means if you can clearly say which lobe. So this is a cranial lung lobe, so middle lung lobe, apical. So that means if only one lobe of the lung is affected with pneumonia, that means if it develops air bronchogram, that means if the density or the opacity has changed, and if the other lung lobe is perfectly normal, that transition between the lobes, that means affected lobe and a normal one, that is called a lobar signs. So that means if we can specifically demarcate each and every lobe because there is no much consolidation, then that is called as a lobar signs. In case of alveolar pattern, you can clearly see the lobar signs. And another thing you have to appreciate in case of an alveolar pattern is a Silhouette effect or a border effacement. So that means here you can see the shadow, the heart is supposed to come here. But the sad thing is that you cannot clearly demarcate the shadows. So the borders of this each and every organ has, if it is lost, that means if you cannot clearly say where is the border of the organ, then that is called a border effacement. So that makes it very difficult for you to say where is the organ comes. So these are all the classical things. If it is appear on a radiograph, you can declare that this is an alveolar pattern, and then animal may be suffering from severe pneumonia changes. So normally in case of pneumonia, the animal will be having an alveolar pattern. Next comes the miliary pattern. So miliary pattern is sand-like particles are scattered here and there. You can see this is in case of lateral radiograph, and also in the same animal on the ventrodorsal radiograph, you can see the entire lung is having a miliary pattern. So nodule, so like a sand particles. So if you want to say that is a miliary pattern, all the sand-like material should be of the size of 2 to 3 mm. Maximum it is a 2 to 3 mm. If it is there, then that is called as a miliary pattern. And another one is called a nodular pattern. So that means if the size of the pattern, so the miliary patterns coalesce together, and if that takes a size of 2 to 3 centimeter in size, up to 3 centimeter, then that is called as a nodular pattern. So when the size of the nodule is more than 3 centimeter, it is no more called as a nodule. It has to be called as a mass there itself. So normally in this nodular pattern will develop when there is some metastasis. As you all know, in case of all mammary tumors in terminal stages, there will be metastasis to the lungs, and what you can appreciate will be you can see the nodules here and there. Sometimes these nodules also may coalesce together to form a large mass. As in case of not only mammary tumor and prostatic CA, osteosarcoma, and in many of the tumor masses, you will see the nodular pattern, or rather you can say later it can become masses in the thorax. The next, the pulmonary pattern will be the vascular pattern. Vascular pattern normally develops when there is an enlarged vessels, which increases the soft tissue opacity in the lung pattern. So here you can appreciate, so the lung is losing its normal black texture because of the air, and that is the much more opacity is appreciated there, and this opacity is mainly because of the enlarged vessels. So when I told you this is a pulmonary vessel, here you can appreciate clearly see the pulmonary artery, and this is a pulmonary artery to the left, the cranial lung lobe, and this is a pulmonary vessel. And I hope you can clearly see this one. This is a pulmonary vessel, and this is a pulmonary artery to the cranial lung lobe, and these are all the pulmonary arteries and the vessels or vein to the caudal lung lobe. This is a posterior vena cava, and here comes the aorta. You see, if all the pulmonary vessels will become much more visualized, and that takes away the clarity or the opacity or the lungs area, then that is called as a vascular pattern. This is very clear representation in case of left-sided congestive heart failure, or even in case of heartworm disease, or also left to right shunting of the heart also can result in a vascular pattern where all the vessels will become much more prominent, making the lung area or the thorax much more opaque. So this is called a vascular pattern. You have again an interstitial pattern also. Interstitial pattern is there. So if you cannot specifically say what type of a pattern is there, that means it's a mixture of the. So here you can see an air bronchogram, and here you can see a vascular pattern. And if you can see not the miliary pattern is an alveolar pattern also, if it is there, and sometimes you can see some bronchial pattern also. If it's a mixture of all these patterns, then normally this is called as an interstitial pattern. And normally this will develop in case of pulmonary fibrosis and early microfilariasis, or in case of interstitial edema, or in case of viral pneumonia. In all the viral pneumonia conditions, the animal will develop an interstitial type of pattern. This may not be very specific. So it means a mixture of all these things what we have discussed, like bronchial, alveolar, and vascular pattern. Then that type of pulmonary pattern is called as an interstitial pattern. This is very common in case of all viral pneumonias. I think you have the diagnosis here. Yes, you might have told it. So here you can appreciate a lot of density here. This is after giving a barium, the animal having severe dyspnea. This is nothing but, again, you cannot appreciate the diaphragm shadow. The diaphragm shadow is lost. That means all these structures, intestine is there in the thorax. It's nothing but a diaphragmatic hernia. This is diaphragmatic hernia. So whenever you get a radiograph for interpretation or the cardiac shadow, always keep it in mind. Cardiac silhouette. Next, we are going to see the cardiac silhouette. Cardiac silhouette is nothing but the summation shadow of 4 chambers. Cardiac size and shape may vary with cardiac cycles. The apparent cardiac size will vary with the respiratory phase, and also it varies with the thoracic conformations. These are all the things you have to keep it in mind when you are going to see the silhouette of the heart for finding out any disease. And these are all the questions you need to ask when you sit with a radiograph to interpret the heart. So if there is any cardiomegaly present, so this would be your first question to ask. If yes, whether it is a right-sided or it's a left-sided or it's a generalized cardiomegaly. Is it limited to a specific chamber alone? Is there an enlargement of the pulmonary veins, pulmonary arteries, or both? Is there an enlargement of the major vessels, including aorta? And is there any radiographic evidence of the left-sided congestive heart failure or right-sided congestive heart failure? And many times, left-sided congestive heart failure will be depicted or with a having symptom like pulmonary edema, and right-sided congestive heart failure will have a symptom like a pleural effusions. These are all things you have to look into when you want to have an interpretation of the heart. And this will be the normal image of the heart you are getting. And if you, in nutshell, you can see this is a carina. This is a carina means this area where the trachea is getting bifurcated into two bronchi. So this is a carina. You can see increased density here because you have the double density with air. And if you draw a line from this carina to the apex of the heart, this is apex of the heart, and this is a hilar region. And if you start draw a line from the carina to the apex of the heart, the area in front of the heart, front of this line, represents the right side heart, and the area behind this line represents the left side heart. So if you draw a line from the carina to the apex of the heart, the area in front is the right side heart, and the area behind is the left side heart. And this is so in case of left side itself, and this area represents the left atrium. This is the left ventricle. Up to this area is the right ventricle, and this is the right atrium. So here you have the left ventricle, left atrium here, left ventricle here, right ventricle here, and the right atrium here. Here you have the posterior vena cava also. To make it much more clear, you can see this is called as a clock face analogy. Clock face analogy says that, so if you are considering the heart as a round clock, here you can appreciate at the region of the 11 o'clock to 1 o'clock, you have the area for the aorta. So this is the aorta, the start of aorta from the heart. So from 1 o'clock to 2 o'clock, you can see all the pulmonary arteries developing from this area, pulmonary arteries and pulmonary vessels or veins, which is going to the caudal lung lobes from here. And then 2 to 3 represent the left atrium. So this is the left atrium. And from 3 to 6 o'clock, it is the left ventricle. And from 6 to 9 represent the right ventricle. And from 9 to 11, you have the right atrium. So this is actually clock face analogy, which depicts all these structures originating from the heart. And again, if it is a ventrodorsal radiograph, again you can see the clock face analogy work here as well. Here you can see this is the area for the aorta, and this is actually representing the left atrium. This is the left ventricle, the right ventricle, and the left atrium. And here you can see the aorta will be taking a curve like this. And here comes the posterior vena cava comes here, and all the pulmonary vessels to the caudal lung lobe also appear here. So this is called the clock face analogy. And if you have an idea about what are all the structures coming here, it will be easy for you to give a diagnosis. In nutshell, in a simple way, if you can say, if you get the cardiac silhouette, which is the rule of thumb says that it should be occupying 2.5 to 3.5 times intercostal spaces. That means here you can see it is taking its own 2 and 3, so 2.5. So that means this is a normal heart. If it is occupying more than, if it is taking more than 3.5 intercostal spaces, you can say that there is a cardiomegaly. So that means that there is enlargement of the heart, but you cannot specifically say that which chamber is enlarged, but in nutshell you can say there is a cardiac enlargement. And not only that intercostal spaces, if you want to see the sternal contact, you can see here there is this is a sternobrae 1, 2, 3. So the heart is having 3 sternobrae contact. So that is allowed. So if there is more than 3 sternobrae contact, that means if the heart is having a contact up to this, then that is called as a heart sitting on the sternum, and clearly depicts that it's a right ventricular enlargement. So this area is called right ventricle, and this if there is more than 3 sternobrae contact, that clearly says that there will be a right ventricular enlargement. So heart should not exceed more than 3 intercostal spaces, and there should not exceed more sternobrae contact. And this is another rule by which you can say whether there is cardiac enlargement or not. So vertical height of the heart. If you take the height of the heart, this is actually the height of the heart at the eighth rib. At the space of the eighth rib, you can measure this height. This is actually the height of the heart, and this is actually the height of the thorax, and this is actually the height of the heart. And the theory says that if this height of the heart is more than 65 times, 65%, if it is more than 65% of this one, the height of the thorax, then there is a cardiac enlargement. Likewise, if you say the width of the chest, then also at the eighth rib space, and this you are taking the width of the heart as well. And if it is more than 50% of this length, and then also you can say that there is a mild cardiac enlargement. Okay, this is another method of saying that whether there is any the enlargement of the heart or not. And again, cardiac size, you can measure it. And if you draw a line from the carina to apex of the heart, just as we have done earlier, so this represents. So this is actually, I told you, this is a right side heart. And normally there should be 2/3 of the heart should be there in front of the line representing the right side heart. 1/3 should be behind the line representing the left side heart. That means if there is more than 2/3 in front of the line, then that says that right side heart is enlarged. Or if it is more than 1/3 behind the line, that says that left side heart is enlarged. Now you are much more specific. You can say the side just by saying cardiac size 2/3, 1/3 rule. It's very easy for you to say whether there is any other side enlargement as well. And another method by which you can say is actually you have to calculate the long axis. Long axis means from the carina to the apex. You calculate this one, take the length of this one, and you can calculate it in millimeters or in centimeters. Then take the width of the heart. So width of the heart is actually exactly the perpendicular line. This is actually the line towards the apex of the heart, the length of the heart, and you take the width of the heart also. So that the width at the area where there is a maximum width you can appreciate. So you add this long axis plus short axis width, and you measure. This is actually the thoracic fourth vertebra. You measure the length of this the thoracic fourth vertebral body and multiply it with 9.7. So you'll get a value. And if the value what you get by adding this long axis and short axis, if it is more than this value, it says that there is a cardiomegaly. Okay, so you have to calculate the long axis of the heart, short axis of the heart, that is width of the heart, add these two, and take the measurement of the length of the fourth thoracic vertebral body and multiply it with 9.7. And if that value is what you get by adding long axis and short axis is more than that value, and then also there is cardiac enlargement. And the next is the vertebral heart size, VHS. This is actually the internationally accepted method of calculating whether there is a cardiac enlargement or not. For this also, you need to measure the long axis or the length of the height of the heart or the length of the heart. You have to measure, and then you have to measure the width of the heart as well. So after measuring this one, you have to scale it and take it from the fourth thoracic vertebra, and now count the number of vertebral bodies coming in between. So that means here you can see, if you are scaling this long axis, you can see here 1, 2, 3, 4, and 5. After 5, you have a small portion here. So that means you have given a value 5.2. So here again, to take the short axis and scale it from 3/4. Then you are getting a value 1, 2, 3, 4, and 5. Okay, so now you have 5.2 plus 5. You can add it, and you are getting a value which is called as a 10.2. So this 10.2 is the vertebral heart size, VHS, of this particular animal. So if you see this value to anyone, so any doctor or any physician will get an idea what is actually the size of the heart. So that is called VHS, and this is supposed to be the most ideal and the accurate method of measuring the size of the heart. And VHS has been given to different breeds of dogs like this. So boxer, it is allowed is for 10.3 to 12 up to 12.6 is allowed, and for Labrador dogs it is 9.9 to 11.7. And in case of spaniels, you can have 9.9 to 11.7 is up to it's allowed. In case of whippet, it is 11 to 11.0. This is actually roughly you can say 9.5 to 12.5. Up to 12.5 can be. So 11.5 is okay. Up to 12.5 is allowed in case of boxer only. But rather this will be the range. You have to keep it in mind. This is the range of VHS, and accordingly you have to diagnose the condition. So if you want to specifically say whether there is any chamber enlargement, and this is normally done with the left atrium. So here is a left atrium, and there is another formula. This is called as a vertebral left atrial size, VLAS. Here you can see this is done by measuring the length between the ventral wall of the carina to the dorsal wall of the caudal vena cava. Here you can see the caudal vena cava, and see this is representing the atrium, left atrium. Here you can appreciate a clear bulge of the left atrium. But if you want to clearly quantify it, what we can do is that you draw a line from the ventral border of the carina to the dorsal wall of this is the posterior vena cava, and this take this length and this scale it with from the T4 vertebra, and you can count the number of vertebral bodies coming. Here the value is coming as 2.8. So normal allowed value for VLAS is 2.3. So that means up to 2.3 vertebral body length is allowed for a normal left atrium. If it exceeds that value, you can clearly say that there is left atrial enlargement. Here in this image, it is very clear that there is a left side enlargement and specifically left atrial enlargement. So again, another feature what we can see is that there is actually a dorsal concavity of this the dorsal border of the caudodorsal border of the heart. Again, clearly says that there could be left atrial enlargement. So this is another mechanism by which you can specifically value or measure a chamber, because left atrial enlargement is the most common problems what you will encounter in case of heart failure as well. Again, channel contact, this also we have discussed. There should be normally there's a 3 Sternberg contact is allowed, and if there is more than 3 Sternberg contact, of course it can be considered as a cardiomegaly, and mainly specifically you can say right ventricular enlargement. And this is actually a condition where you can see cardiomegaly. Obviously, it could be a lot of conditions can lead to cardiomegaly that we need to discuss. And it could be a muscular hypertrophy, or it can be due to chamber dilatation, or even it can be pericardial fluid accumulation also will lead to cardiomegaly. That each and every condition we have to differentiate from the correlating with the other symptoms as well. And I think you have a diagnosis here. Again, it's very specific, and that area has been taken. This is actually the left atrium. So specifically, you can see one chamber has been enlarged. This makes it much more clear. Here you can appreciate a left atrial enlargement, and this is actually the carina. And if you want to correctly measure what is the size, you have to measure. So this here you have the posterior vena cava size here, and you have to draw a line up to this one and take it, then scale it and calculate it from the T4. And that we your value, and that is a mechanism by which you can quantify what much size is a left atrium. Okay, so left atrial enlargement is very common in case of congestive left side congestive heart failure. It will be associated with a little bit of pulmonary edema, cardiogenic pulmonary edema as well. And this is nothing but a cardiomegaly due to mitral valve insufficiency. So mitral valve is there in the left side heart. If there is any mitral valve regurgitation or mitral valve insufficiency, or in case of aortic valve insufficiency also, you can appreciate there will be the left atrial enlargement, and subsequently leading to a lot of the pulmonary edema as well. Pulmonary edema, and also leading to coughing, and this may lead to enlargement of the heart, which is called cardiomegaly. And here you can see a left-sided congestive heart failure. And why or how we can say that there is heart failure is that because this is actually the area, this is a pulmonary edema. This edema could be because of the left failure of the left atrium. So if left side heart, it is not very that much clear here. Here you can appreciate kinging of the trachea as well. So kinging of the trachea can be because from the right atrial enlargement. And when there is a left atrial enlargement, what may happen is that this also will press on the trachea. This will apply pressure on the trachea, and sometimes it will be made almost parallel to the vertebral column. So that much enlargement can happen with the left atrial enlargement. And in case of congestive heart failure, left-sided congestive heart failure, you will see pulmonary edema and also very prominent pulmonary vessels. Here you can appreciate this is a pulmonary artery and this is a pulmonary vein. So here you can see the difference. The pulmonary vein is taking a much more larger diameter than the artery. and the maximum diameter allowed for the pulmonary vessel is it should not exceed more than the third rib diameter. So this much length is maximum allowed. So here you can appreciate pulmonary vein is having a much more diameter than not allowed. So all these things are classical of left-sided congestive heart failure. So this can result in the right side also, because many times right-sided heart failure will be subsequent to left-sided congestive heart failure of the patient. Here you can see a dog presented with severe coughing. Again, here if you look into the lateral radiograph of the animal, here again you can appreciate the cardiac silhouette has been lost. Some little bit of pericardial fluid could be appreciated, and this is an area where you can say a lot of edema, pulmonary edema is there. And many times it could be because, as we have discussed, it could be because of the maybe congestive heart failure also. The left atrial enlargement also can be appreciated, and you can appreciate here these are all the pulmonary vessels to the cranial lung lobe, to the caudal lung lobe, and again there is a pressing of the lifting of the trachea also can be appreciated. This is, as I told you, this is a classical image in case of left atrial enlargement. Here you can see the pressure on the primary bronchi. Here you can appreciate the narrowness of the primary bronchi. In this case, definitely because of the pressure in the primary bronchi, animal will have coughing. This is called a cardiac cough. Cardiac cough, a dry, non-productive cough, and that mainly happens because of the pressure on the primary bronchi because of the dilated or enlarged left atrium. And I told you there is a tracheal lifting. This trachea has been lifted, and here you can appreciate the trachea is running almost parallel. Normally, this should not be running parallel to the dorsal, this vertebral column. Here you can appreciate the trachea is running almost parallel. This clearly says that there will be there is the right the left atrial enlargement also, and the left side cardiomegaly. And the venereal radiograph of the same animal has been taken. You can appreciate this is actually the left side. So left atrium and also the left ventricle, entire left side is now is enlarged. Here you can appreciate the left side, and it is occupying almost from the middle mediastinum. It is almost occupying the entire left side of the. Okay, so this is actually left side congestive heart failure. And coming to this one, I think you have a diagnosis here now. Now the structures normally visible should be starting from the diaphragm. So the diaphragm silhouette is not that much clear here, but anyway you can have the diaphragm here. But the cardiac silhouette is not at all visible. So the entire space is filled with some soft tissue opacity, so some opacity is there. So normally this is actually a fluid opacity here you can appreciate. So the fluid opacity which completely marks the shadow or cardiac silhouette may be there in the pleura. So this is nothing but the start of the pleural effusion. I told you it starts like pleuritis, where there you can see the pleural fissure. A stage will come when in case of animal patients, a stage, it will be brought to us when a stage there is actually the pleural effusions. So when you get a radiograph, the animal presented with severe coughing, respiratory distress, and if you get a radiograph and you cannot appreciate any structure clearly demarcated structures like a cardiac silhouette, nothing is visible, then you have to suspect some fluid inside in the pleura. See, need not always be the pleural effusions alone. It could be even sometimes blood or hemorrhage or even the chyle. Also said that is called as a chylothorax, or is even you can say that could be hemothorax as well. So what all may be, if you are losing the entire cardiac silhouette margin, and if none of the structure can be easily diagnosed, you can say there is some fluid, the intensive presence there in the pleura. Here it's much more clear. Again, the density is increased here, and the cardiac silhouette also is not at all visible. So pleural effusion, and in the start phase, you can see there will be pleural fissure. So normally in case of cardiac, I have enlarged it. Here you can appreciate this is actually the cardiac fissure. Initially it will appear, a cardiac fissure will appear, and this pleural fissure, and this is representing the lobes. Between the lobes you can see the pleural fold and pleural fissure. In case of pleuritis, it starts with a pleural fissure, later develops into pleural effusions. See, here you can see again in case of venereal radiograph also, this is actually representing the right side. So this the pleural, you can appreciate the pleural fissure here. And many times in case of lateral radiograph, we will miss it. We will miss it in case of this pleural effusion, because in patients will become more symptomatic when it's actually converted into a pleural effusions. So keep in mind. So pleural fissure will develop first when the animal develops pleurite, this inflammation itself, and slowly changing towards the pleural effusions. Here you can see a right radiograph showing the pleural fissure here. So if you see structures like this, so don't confuse it with the pulmonary vessels. So these are all the pulmonary vessels here and there, this vena cava. And if you see some folds, then this should be diagnosed as a pleural fissure. Again, I think now you have a diagnosis here. There also, this is an extreme degree of pleural effusions. You cannot appreciate any structures there inside the structures enter. The thorax is now filled with fluid, or rather you can say pleural effusions. And again, all things, all these X-rays where there is any shadowing or masking of the cardiac silhouette should not be confused with the pleural effusions. There could be conditions called pseudo effusion, wherein this is nothing but the fat. Here you can see there is no sternal contact for the heart, or rather you can say the heart is lifted. And but this area you have a little bit of opacity, so this opacity is for the fat. But the difference between the pseudo effusion and also that means a fat and pleural effusion is that in case of pleural effusion, it is absolutely not possible for you to see any cardiac silhouette. Whereas in case of pseudo effusion, or if there is fat, you can clearly demarcate or differentiate the cardiac silhouette here. I think this is the one. This you can clearly see the cardiac silhouette, and but there is no contact and some the mass, soft tissue mass inside. So that is actually a fat. So there is a lot of fat in the heart. Then also it will feel like, you will feel like there is a pseudo effusions also. Okay. Again, here you can appreciate a swelling here on the cranial. So this is actually representing the cranial lung lobe, and here is this area for the right atrium. So this is right atrium enlargement. So when there is right atrium enlargement, that will also press on the trachea. But the pressure on the trachea will be much more when there is a left atrial enlargement. So that will make it parallel. And I told you it will be, if there is a left atrial enlargement, this will be made almost parallel. Here you can appreciate there is no left atrial enlargement, or left side enlargement is not there. At the same time, you can see the right side heart is enlarged. So there is a obviously right atrial enlargement. Right ventricular enlargement also is not appreciated. Okay. So here, this is actually another condition where you can see a lot of pulmonary edema. So this is an area where you have to see whether there is for any clarity. If there you are losing or the clarity, or if you see more opacity here, this could be cardiogenic pulmonary edema. And another thing you have to keep it in mind is that this area you have the tracheobronchial lymph node as well. So tracheobronchial lymph node also may get enlarged, and that also get a confusion like pulmonary edema. So the another condition is called pericardial effusion. So here you can see this is a typical condition in which there is pericardial effusion. You can appreciate a round globoid heart. This is nothing but this is called as a pumpkin heart. Pumpkin heart, or the saucer ball shaped cardiac silhouette, if you're appreciating, that clearly says that there is a pericardial effusion. So the cardiac silhouette as such is completely enlarged, and definitely there the trachea will be elevated. Here you can see the tracheal kinking starts from here, and trachea is elevated, and the heart is totally round in shape. If you see a round globoid heart, that is called a pumpkin heart, and then that clearly says that there is a pericardial effusion. And another condition is called pneumothorax, where what happens is that air enters into the thorax. Here you can appreciate there the heart will be lifted, and it takes a feel like heart is floating in the lungs. So it will be just a heart floating in the lungs. It's there is no contact with the sternum, and if you see entire area air, this can happen when there is any trauma to the thorax, any external trauma, or if there is a rupture of the pulmonary bulla also. Pulmonary bulla also, air can get escape into the thorax and again give rise to a condition called a pneumothorax. And in case of radiograph, the classical thing is that you will see appreciate heart actually like floating in an air bag. So that is called a pneumothorax. And another condition, what you can appreciate is a cor pulmonale. Cor pulmonale is nothing but the right heart enlargement due to pulmonary diseases. So pulmonary diseases means when the pulmonary blood flow is obstructed, leading to pulmonary hypertension, it can result in a condition. Here you can see all the pulmonary vessels are very much tortuous and engorged. Here you can see the pulmonary vessels to the cranial lung lobe, pulmonary artery and the pulmonary veins. If all the pulmonary vessels are engorged, many times this may happen with heartworm disease, and large pulmonary arterioles can be appreciated, and that is called as the cor pulmonale. And this is the area I told you. This could be so tracheobronchial lymph node also comes here, this area, and if there is enlargement, the tracheobronchial lymph node also should be considered when you see this opacity here in this region. So here you can see again there is a lymph node. This mediastinal lymph node also is there. So presence of the enlargement of the mediastinal lymph node also will take away the clarity or the opacity of the lung here, which will give much more opaque lungs here. So mediastinal lymph node and the external lymph node also can be appreciated, not here, but still then keep it in mind. There could be mediastinal lymph node here, times thymus, and the tracheobronchial lymph node also. Inflammation of all these structures also should be taken care when you read the cardiac images. Another condition is called microcardia. This image is not all clear. It's an abnormally small heart is called as a microcardia. So normally this happens in case of hypovolemic shock, in case of dehydration, also in hypoadrenocorticism. You will see an abnormally small heart which is called as a microcardia. And I think this all of you may be able to diagnose this condition. I think you have an answer. Everyone have an answer. This is an accidental ingestion of the barium. So we have given barium for confirming megaesophagus, and it got accidentally gulped and it got into the trachea, and now you can see the entire bronchi got bronchial tree. You can appreciate it got aspirated, and the animal developed aspiration pneumonia and later it died. So we should be very careful when you give offer barium to the animal. Never get it aspirated. And this is actually another condition where you can see this is actually after giving a barium. This is the diverticulum, esophageal diverticulum. So this is a thoracic esophageal diverticulum. So there is a dilatation of esophagus, and this is now with after giving contrast. And I think now you have a diagnosis here. A lot of nodules you can appreciate here and there. This is nothing but a nodular pattern of the lung, and can happen in case of metastasis with any of the tumor, including the mammary tumor as well. And this is a very peculiar case. I think everyone can appreciate the changes here. So this is a heartbeat, this is a hilar region, and there you can see an abnormal large density pushing the trachea unusually high, lifted. Tracheal king, not only tracheal king, here as well you can appreciate the tracheal king. Trachea is unusually lifted, and that much pressure is developing from the hilar region of the base of the heart. And this is a totally confusing one. So it could be a tumor mass originating here at the base of the heart, or I told you there is a lymph node, tracheobronchial lymph node. So tracheobronchial lymph node also can get severely enlarged at the time. It can even press on the trachea like this one. So this animal was presented with a severe cough, and later this was diagnosed as a heart-based tumor. So, but always whenever you are going for a diagnosis, you should have a differentials, and one of the differentials you should keep it in mind when you get such type of radiograph should be along with the tumor. Always keep it in mind some tracheobronchial lymph node as well. So another one in another thing what we can appreciate in the thorax will be tracheal collapse. So you have a narrow trachea here. You can appreciate the tracheal collapse. So different grades of tracheal collapse is there, and when it enters in the thoracic cavity, you can appreciate the narrowness of the trachea, and you can calculate the tracheal index. So you have to. So in case of small breeds like brachycephalic breeds of dog, you will have a narrow thoracic inlet. There you can see brachycephalic syndrome. There you can see the diameter of the trachea will be very narrow. So you can have an index. So by calculating the diameter of the trachea, dividing it with the thoracic inlet height. So that is at the region of the first rib. So if the value is less than 0.2, that means it's okay. So when if it is less than 0.2, that means there is a varying degrees of tracheal collapse. And always, whenever you see a narrow trachea, never confuse it with or don't think that always it could be a tracheal collapse. You always keep it in mind there is a possibility of redundant tracheal membrane as well. So here you can appreciate it. So how can you appreciate it? Is that here you can see the normal tracheal wall here. Normal tracheal wall is here, and some soft tissue structure is hanging there. So this is nothing but a tracheal wall, bro. You see the tracheal membrane. It's actually when it became redundant, that may be hanging into the trachea. This also will give, say, the classical symptom like goose honking cough will be there because of the narrowing of the passage. But actually, the trachea is not fully collapsed here. So always keep this also in mind when you get a goose honking cough and you get a collapsed trachea on radiograph, and rule out whether there is no redundant tracheal membrane. And I think you have an answer there. You can see some air pocket here in the neck region itself, and a hard mass. And from the on the top of the base of the heart, you can appreciate a huge sordid structure here, a foreign body obstructing the trachea. And at times, when you get a thoracic radiograph, you may sometimes end up with some foreign bodies as well there. Another thing you have to keep in mind is a tracheo-esophageal stripe sign. This is very important. So this is nothing but the silhouetting of the ventral esophageal and the dorsal tracheal wall. This is a classical symptom in case of megaesophagus. So when there is megaesophagus, what can happen is that inside the esophagus, you will see the air pockets. So when there is air pocket and there is a silhouetting effect, so esophagus will be sagging over the trachea, and the dorsal tracheal wall and also the ventral esophageal wall will get highlighted. So this is called this highlighting of the dorsal tracheal wall and the ventral esophageal wall due to the presence of air is called as a tracheobronchial stripe sign, and this is a classical of megaesophagus. So never stop by seeing tracheal stripe sign. You need to go for a barium contrast and confirm it. But always keep it in mind, in a plain radiograph itself, megaesophagus can be easily diagnosed by seeing tracheobronchial stripe signs. This should not be confused with a pneumomediastinum, where you can see both the entire line of esophagus and trachea will be highlighted. Whereas in this case, wherever there is overlapping of the trachea on the trachea, overlapping of the esophagus on the trachea only will be highlighted, or silhouetting effect will be there. That is called the esophageal stripe signs. And this is easy for you to diagnose. This is after giving a barium. So now you have the megaesophagus. The thoracic esophagus also is also dilated. And this is an animal presented with severe coughing and vomiting. Rather, you can say regurgitation immediately after taking food and immediately after weaning. The barium has been given, and you can see the entire esophagus and a particular portion has been completely is dilated, and the entire barium was retained there. This is nothing but persistent right aortic arch. This also this is a right aortic arch, and there is a persistence because of the persistence of the right aortic arch. Esophagus is getting pocketed there, and when the animal is changing from the liquid food, or rather immediately after weaning, when it is offered solid food, this entire esophagus may get dilated and from a pouch in front of the right aortic arch, and that gives a classical vomiting, and this has to be removed surgically. So this is called PRIA. These are all the structures you can appreciate in the thorax, or rather you need to go for when you think about interpreting the thoracic radiograph. I'm concluding, and always, so just if you want to have a diagnosis or you want to make any comment on a thoracic radiograph, always go for orthogonal views and make sure that you are not missing or any structure there by taking a simple view, and observe without a prejudiced mind. So in a free mind, you just have a look outside in the entire radiograph and then only give a diagnosis. And always keep in mind, radiography is not the final word. It is only an imaging technique. You need further imaging for sure. And in case of veterinary practice, in case of cardiac imaging, you have echocardiography by which you can correctly confirm the conditions of what you have diagnosed from the radiography. But we don't have much. In veterinary practice, we don't have much advanced diagnostic imaging like CT, MRI. But so that is the reason why we need to go for or should have a correct idea about interpreting the thoracic radiograph, because there is not too much of the diagnostic techniques for the time being. It's available for veterinary practice. And I know the condition of you all will be this, and take it from me, this is not the end, this is only the start. You need to have a long process of interpreting a radiograph, because if you do a lot of exercise, then only you'll be able to come up with a correct diagnosis.